This is the continuation of cardiac dysrhythmias. In this video, we will cover atrial dysrhythmias. Atrial dysrhythmia originates from foci within the atria and not the SA node. Atrial dysrhythmia originates from anywhere in the atria, not from SA node. These include aberrancies such as premature atrial complexes, atrial fibrillation, atrial flutter. First, we will see premature atrial complex. A premature atrial complex is a single ECG complex that occurs when an electrical impulse starts in the atrium before the next normal impulse of the sinus node. Premature atrial complexes are common in normal hearts. The patient may say, "My heart skipped a beat." A pulse deficit, that is, a difference between the apical and radial pulse, may exist. Premature atrial contractions are occasional extra heartbeats that disturb the normal rhythm of the heart. They arise when an unexpected area in the heart fires an electrical impulse that triggers a heartbeat. It may or may not cause noticeable symptoms. The unexpected signal fires sooner than it should, that is prematurely, creating an extra abnormal heartbeat and briefly disrupting the normal heart rhythm. The causes of premature atrial complexes are stress, anxiety, fatigue. It can be because of infection, can be because of caffeine, nicotine or alcohol intake, drugs such as epinephrine, sympathomimetics, amphetamines, digoxin or anesthetic agents. It can be because of stretched atrial myocardium, because of hyperolemia. Patient with hypokalemia, that is low potassium level, patient with hypermetabolic states with pregnancy or atrial ischemia, injury or infection. Premature atrial complexes are often seen with sinus tachycardia also. Characteristics of PACs are: ventricular and atrial rate depends on the underlying rhythm. If the patient is having sinus tachycardia, the rate will be greater than 100 beats per minute. Ventricular and atrial rhythm will be irregular due to yearly P waves, creating a PP interval that is shorter than the others. This is sometimes followed by a longer than normal PP interval, but one that is less than twice the normal PP interval. This type of interval is called a non-compensatory pause. QRS, shape and duration. The QRS that follows the yearly P wave is usually normal, but it may be abnormal in aberrantly conducted PACs. It may even be absent in blocked PACs. P wave. An early and different P wave may be seen or may be hidden in the T wave. Other P waves in the strip are consistent. PR interval. The yearly P wave has a shorter than normal PR interval, but still between 0.12 and 0.2 seconds. P is to QRS ratio usually 1:1. Premature complexes may occur repetitively in a rhythmic fashion. Bigeminy exists when normal complexes and premature complexes occur alternatively in a repetitive 2-beat pattern, which a pause occurring after each premature complex, so complexes occur in pairs. Trigeminy is a repeated 3-beat pattern, usually occurring as 2 sequential normal complexes followed by a premature complex and a pause, with the same pattern repeating itself in triplets. Quadrigeminy is a repeated 4-beat pattern, usually occurring as 3 sequential normal complexes followed by a premature complex and a pause, with the same pattern repeating itself in a 4-beat pattern. Now let us see the clinical significances. In a person with a healthy heart, isolated PACs are not significant. Patients may report palpitations or sense that the heart skipped a beat. In a person with heart disease, frequent PACs may indicate enhanced automaticity of the heart or a re-entry mechanism. Such PACs may warn of or start more serious dysrhythmias, for example, supraventricular tachycardia. The patient may experience heart palpitations, fluttering feelings in the chest or throat, feeling that the heart has skipped a beat, feeling that the heart has beat an extra time, a brief moment of dizziness or feeling faint. Arrhythmias are produced by one of the 3 mechanisms: re-entry, enhanced automaticity, or triggered activity. Automaticity is the property of cardiac cells to generate spontaneous action potentials. Automaticity is the spontaneous depolarization of tissue, which is physiologic in the sinus and atrioventricular node and the His bundle. This is a contrast to triggered activity, which is abnormal impulse generation in response to a previous stimulus. Re-entry is a mechanism of pathologic impulse conduction. Re-entry is connected to structural heart disease, whereas automaticity and triggered activity may be found in structurally normal hearts. Re-entry is the most common mechanism of arrhythmia, and it is responsible for the majority of supraventricular as well as ventricular tachycardias. Re-entry describes a self-sustaining cardiac rhythm abnormality. In re-entry, the action potential propagates in a circus-like closed-loop manner. It is a disorder of impulse conduction and thus describes one kind of arrhythmogenesis and is differentiated from disorders of impulse generation such as automaticity and triggered activity. Re-entry is fundamentally different from automaticity or triggered activity in the mechanism by which it initiates and sustains cardiac arrhythmias. Now let us see the medical management of PSS. If PSS are infrequent, no treatment is necessary. If they are frequent, more than 6 per minute, this may warn a worsening disease state or the onset of more serious dysrhythmia such as atrial fibrillation. Treatment depends on the patient's symptoms. Sources of stimulation such as caffeine or sympathomimetic drugs may be withdrawn. Beta blockers may be used to decrease PSS. Medical management is directed toward treating the underlying cause, for example, reduction of caffeine intake, correction of hypokalemia. Now let us see atrial fibrillation. Atrial fibrillation is an abnormal heart rhythm characterized by rapid and irregular beating of the atrial chambers of the heart. If anyone have atrial fibrillation, the normal cycle of electrical impulses in the heart is interrupted. This leads to a fast, chaotic heart rhythm and a poor movement of blood from atria to lower chambers, that is, ventricles. Atrial fibrillation is characterized by total disorganization of atrial electrical activity because of multiple ectopic foci. Ectopic foci are abnormal pacemaker sites within the heart outside the SNR that display automaticity. They can occur within the atria or ventricles. Atrial fibrillation is associated with structural, electrical, and contractile remodeling of the atria. Any persistent change in atrial structure or function constitutes atrial remodeling. Many forms of atrial remodeling promote the occurrence or maintenance of atrial fibrillation by acting on the fundamental arrhythmia mechanisms. Atrial fibrillation causes electrophysiologic changes in the atrial myocardium, that is, remodeling of the atrial electrical circuit or conduction, and structural remodeling, that is, fibrosis, which provides the basis for continuance of the dysarrhythmia. The effectiveness of atrial contraction will be lost because of electrophysiological changes in the atrial myocardium and structural remodeling. The hallmark of structural remodeling of the atria is fibrosis. Atrial fibrosis produces a substrate or substance to promote atrial fibrillation by interrupting fiber bundle continuity, causing local conduction disturbances. The dysarrhythmia may be paroxysmal, that is, beginning and ending spontaneously, or persistent. It lasts for more than 7 days. Atrial fibrillation is the most common clinically significant dysarrhythmia with respect to morbidity and mortality rates and economic impact. Atrial fibrillation can result from diverse pathophysiologic etiologies and risk. The risk factors of atrial fibrillations are increasing age, hypertension, diabetes, hyperthyroidism, person who is having obese, valvular heart disease, heart failure, a person with obstructive sleep apnea, alcohol consumption, cardiac ischemia, persons who is having cardiac inflammatory disease such as pericarditis, myocarditis, amyloidosis. Cardiac amyloidosis occurs when amyloid fibrils or proteins accumulate within the cardiac tissue, which is a condition that leads to progressive heart failure depending on the stage and the form of cardiac amyloidosis. Persons who is having myocardial hypertrophy, fibrosis or dilation is having the risk for atrial fibrillation. Persons with atrial remodeling and postoperative cardiac surgery is also having the risk for atrial fibrillation. Atrial fibrillation results from abnormal impulse formation that occurs when structural or electrophysiological abnormalities alter the atrial tissue, causing a rapid, disorganized, and uncoordinated twitching of the atrial musculature. Both the extrinsic, that is central, and intrinsic cardiac autonomic nervous system, that is CANS, are taught to play an important role in the initiation and continuance of the atrial fibrillation. The intrinsic cardiac nervous system includes the network of the intracardiac ganglia and interconnecting neurons. The extrinsic part consists of the nuclei in the brainstem and along the thoracic segments of the spinal cord, as well as their axons en route to the heart. Intrinsic autonomic dysfunction arises from diseases that directly affect the autonomic nerves, such as diabetic mellitus and the symptoms of primary autonomic failure. Extrinsic autonomic dysfunction reflects the changes in autonomic function that are secondarily induced by cardiac or other diseases. Hyperactive autonomic ganglia in the CANS are thought to play a critical role in atrial fibrillation, resulting in impulses that are initiated from the pulmonary veins and conducted through to the AV node. The ventricular rate of response depends on the conduction of atrial impulses through the AV node, presence of accessory electrical conduction pathways, and therapeutic effect of medications. Lack of consistency in describing patterns or types of atrial fibrillation has led to the use of numerous labels. Atrial fibrillation can be classified under many subtypes. First one is occasional, also known as paroxysmal atrial fibrillation. This subtype have symptoms that comes and goes with a duration of a few minutes to hours. In this subtype, manifestation may occur for as long as a week. They may occur repeatedly and may alleviate without any treatment. However, occasional atrial fibrillation would still need therapeutic management. Next subtype is persistent. This subtype is characterized as atrial fibrillation with tenacious manifestations that do not revert to normal heart rhythm. Because of this and its associated life-threatening effects, persistent atrial fibrillation would need cardioversion or other medical therapies in order to reinstate and sustain normal heart rhythm. Next is long-standing persistent, another subtype wherein the patient experiences consistent atrial fibrillation that lasts more than 12 months. Next is permanent. In this subtype, the condition is persistent and therefore would need medications to regulate the heart rate and therefore address the irregular heart rhythm. The use of the term chronic atrial fibrillation is no longer included in the classification system due to a lack of consensus on what constitutes chronicity. Now let us see the characteristics of atrial fibrillation. Atrial rate will be 300 to 600 beats per minute. Ventricular rate is usually 120 to 200 beats per minute in untreated atrial fibrillation. Atrial fibrillation is usually immeasurable because fibrillatory waves replace P waves. Ventricular rate may vary from bradycardia to tachycardia. Ventricular and atrial rhythm will be highly irregular. We will be having difficulty identifying P waves. Irregular undulating waves that vary in amplitude and shapes are seen and referred to as fibrillatory or F waves. P waves replaced by fibrillatory waves, sometimes called little f waves. QRS shape and duration will be usually normal but may be abnormal. PR interval cannot be measured. P raised to QRS ratio is equal to many P waves is to 1. T wave will be normally conducted. Patients with atrial fibrillation are at increased risk of heart failure, myocardial ischemia, embolic events such as stroke. A rapid and irregular ventricular response reduces the time for ventricular filling, resulting in a smaller stroke volume. Because atrial fibrillation causes a loss in AV synchrony, the atria and ventricles contract at different times. The atrial kick, the last part of diastole and ventricular filling, which accounts for 25% to 30% of the cardiac output, is also lost. As a consequence, although some patients with atrial fibrillation are asymptomatic, Others experience palpitations, clinical manifestations of heart failure such as shortness of breath, hypotension, dyspnea on exertion, fatigue. In addition, a high ventricular rate of response during atrial fibrillation that is greater than 80 beats per minute can eventually lead to mitral valve dysfunction, mitral regurgitation. Mitral regurgitation is a heart condition characterized by the incomplete closure of the mitral valve, leading to the backflow of blood from the left ventricle into the left atrium during systole. This results in a systolic murmur heard at the apex of the heart, often radiating to the left axilla, and atrial fibrillation can eventually lead to dilated ventricular cardiomyopathy. Patients with atrial fibrillation may exhibit a pulse deficit, a numeric difference between apical and radial pulse rates. The shorter time in diastole reduces the time available for coronary artery perfusion, thereby increasing the risk of myocardial ischemia with the onset of angina symptoms. Decreasing the ventricular rate may avoid and correct these effects. The erratic nature of atrial contraction, alterations in ventricular ejection, and atrial myocardial dysfunction promotes the formation of thrombi, especially within the left atrium, increasing the risk of an embolic event. Thrombi may form in the atria because of blood stasis, and embolized clot may move through arteries to the brain, causing a stroke. Atrial fibrillation accounts for 1 in 7 strokes. The origin of embolisms resulting in stroke for patients with non-valvular atrial fibrillation is most often the left atrial appendage. The left atrial appendage is a finger-like extension originating from the main body of the left atrium. Now let us see the medical management. Medical management is to prevent embolic events such as stroke with antithrombotic drugs, controlling the ventricular rate of response with antiarrhythmic agents, treating the dysrhythmia as indicated so that it is converted to a sinus rhythm. Let us cover the medications that control the heart rate. A strategy to control the ventricular rate of response so that the resting heart rate is less than 80 beats per minute is recommended in order to manage symptoms of atrial fibrillation. To decrease the ventricular rate in patients with paroxysmal, persistent or permanent atrial fibrillation, a beta blocker, that is class 2 antiarrhythmic drugs, or dihydropyridine calcium channel blocker, that is class 4 antiarrhythmic drug, is generally recommended. If the atrial fibrillation is of recent onset, the cardiologist may choose to revert the rhythm to a sinus rhythm. Digoxin is a second-line drug for rate control because it only controls rate at rest. Medications that convert the heart rhythm or prevent atrial fibrillation. For patients with atrial fibrillation lasting 48 hours or longer, anticoagulation is recommended prior to attempts to restore sinus rhythm, which may be achieved through pharmacological or electrical cardioversion. In the absence of therapeutic anticoagulation, transthoracic echocardiogram may be performed prior to cardioversion to identify left atrial thrombus formation, including in the left atrial appendage. If no thrombus is identified, cardioversion can proceed. Medications that may be given to achieve pharmacological cardioversion to sinus rhythm include flecainide, dofetilide, propafenone, amiodarone, and IV ibutylide. These medications are most effective if given within 7 days of the onset of atrial fibrillation. It is recommended that patients who were prescribed dofetilide to be hospitalized so that the QT interval and renal function both may be monitored. Despite a degree of risk, dofetilide is a preferred medication because it is highly effective at converting atrial fibrillation to sinus rhythm, has fewer drug-to-drug interactions, and is better tolerated by patients than other medications. Some patients with recurrent atrial fibrillation may be prescribed flecainide to self-administer at home, an approach referred to as pill in the pocket. Cardiovascular for recent onset atrial fibrillation may be required starting with low amounts of biphasic electrical current, that is 100 to 200 joules. Chronic anticoagulation therapy may be warranted to prevent microemboli. Now let us cover antithrombotic medications. Antithrombotic drugs may include anticoagulants and antiplatelet drugs. Oral antithrombotic therapy is indicated for most patients with non-valvular atrial fibrillation because it reduces the risk of stroke. Antithrombotic therapy is then selected based on risk factors outlined in the mnemonics CHA2 DS2-VASC, with each risk factor assigned points tallied for a total score that indicates an overall risk of stroke. According to pharmacology treatment guidelines, patients with low stroke risk may choose the option of no antithrombotic therapy or may be placed on aspirin therapy dosed at 75 to 3 to 5 mg daily. Patients with at least moderate risk may choose either warfarin or direct-acting oral anticoagulant or factor XA inhibitor, that is dabigatran, rivaroxaban, abixaban, and edoxaban. What is CHA2 DS2-VASC score? If the patient is having congestive heart failure, the risk for stroke, the point or the score is 1. If the patient is having hypertension, the score is 1. If the person is aged 75 or more than 75 years, the score is double, that is, the point will be 2. If the person is having diabetic mellitus, the point is 1. If the person had prior stroke or TIA or thromboembolism, point is double, that is 2. The person with valvular disease, that is peripheral artery disease or myocardial infarction or aortic plaque, then the score is 1. If the person is aged between 65 to 74, score is 1. If the person is female, the score is 1. Now let us see atrial flutter. Atrial flutter is an arrhythmia that results from an abnormal electrical circuit inside one of our heart's two upper chambers or atria. Most often, this faulty signal develops in the right atrium. Atrial flutter is an atrial tachydysrhythmia identified by recurring, regular, sawtooth-shaped flutter waves originating from a single ectopic focus in the right atrium. It is very less common in left atrium. It causes both of our atria to beat extra fast, about 250 to 350 beats per minute. That in turn causes our heart's two lower chambers or ventricles to pick up the pace as well. They can beat more than 150 times per minute during atrial flutter. By contrast, a normal heartbeat is 60 to 100 beats per minute. An important feature of this dysrhythmia is that the AV node sets up a therapeutic block which don't allow some impulse transmission. This can produce a varying block or fixed block. That is, sometimes the AV node will transmit every second flutter wave, producing a 2:1 block, or the rhythm can be 3:1 or 4:1. If the AV node conducted 1:1, then the outcome would be a ventricular rate of about 300 beats per minute. The patient would rapidly deteriorate. An abnormally fast heart rate is called tachycardia. Because atrial flutter comes from the atria, it is called a supraventricular tachycardia, meaning above the ventricles, that is supraventricular. Atrial flutter occurs because of a conduction defect in the atrium and causes a rapid, regular atrial impulse at a rate between 250 and 400 beats per minute. Because the atrial rate is faster than the AV node can conduct, not all atrial impulses are conducted into the ventricle, causing a therapeutic block at the AV node. This is an important feature of this dysrhythmia. If all atrial impulses were conducted to the ventricles, the ventricular rate would be 250 to 400 beats per minute, which would result in ventricular fibrillation, a life-threatening dysrhythmia. Atrial flutter rarely occurs in a healthy heart. It is associated with coronary artery disease, hypertension, mitral valve disorders, pulmonary embolus, chronic lung diseases, cor pulmonale, Cardiomyopathy, hyperthyroidism, and the use of drugs such as digoxin, quinidine, and epinephrine occurs with atrial stretching or enlargement, as in AV valvular disease, MI, and heart failure. Now let us see the characteristics of atrial flutter. Atrial rate ranges between 250 and 400 beats per minute. Ventricular rate usually ranges between 75 and 150 beats per minute. Atrial rhythm is regular. The ventricular rhythm is usually regular but may be irregular because of a change in the AV conduction. QRS shape and duration usually normal but may be abnormal or may be absent. The shape of the P wave will be sawtoothed. These waves are referred to as F waves. Multiple F waves may make it difficult to determine the PR interval. P is to QRS ratio either 2:1, 3:1, or 4:1. Now let us see the clinical significance of atrial flutter. Atrial flutter doesn't always have symptoms, but it can sometimes have serious consequences if not treated. The high ventricular rates and loss of atrial kick in atrial flutter decreases carbon dioxide. This can cause serious problems such as heart failure, especially in the patient with underlying heart disease. Patients with atrial flutter have an increased risk for stroke because thrombi can form in the atria from the stasis of blood. Atrial flutter can cause serious signs and symptoms such as chest pain, shortness of breath, and low blood pressure. Now we will see medical management. Medical management involves the use of vagal maneuvers or administration of adenosine, which causes sympathetic block and slowing of conduction through the AV node. This may terminate the tachycardia optimally. It will facilitate visualization of flutter waves for diagnostic purposes. Adenosine is given intravenously by rapid administration and immediately followed by a 20 ml saline flush and elevation of the arm with the IV line to promote rapid circulation of the medication. While giving adenosine medications, we have to explain the patient that the patient may feel chest pressure after receiving the medication. Injection site should be as close to the heart as possible. For example, antecubital area is preferred. Give IV dose rapidly over 1 to 2 seconds and follow with a rapid 20 ml normal saline flush. Use a stopcock setup to make sure adenosine gets to the heart quickly. Monitor patient's ECG continuously. Brief period of asystole is common. Assess the patient for flushing, dizziness, chest pain, or palpitations. Atrial flutter is treated with antithrombotic therapy, rate control, and rhythm control in the same manner as atrial fibrillation. The primary goal in treatment of atrial flutter is to slow the ventricular response by increasing AV block. Drugs used to control ventricular rate include calcium channel blockers and beta blockers. Electrical cardioversion may convert the atrial flutter to sinus rhythm in an emergency, for example, when the patient is clinically unstable, or it may be given electively. Antidysrhythmic drugs can convert atrial flutter to sinus rhythm, for example, ibuprofen, or maintain sinus rhythm, that is, drugs of choice are amiodarone or flecainide. Radiofrequency catheter ablation in an EPS laboratory, that is electrophysiological studies, is the treatment of choice for atrial flutter. Low voltage, high frequency electrical energy is used to ablate or destroy the ectopic foci through a catheter in the right atrium. This should restore normal sinus rhythm. These are all about atrial dysrhythmia.